Welcome everyone to the second colloquium of the Andromeda Research Network. We are super happy to be sharing with our community and with these renowned professors, in which today we will discuss a very interesting topic, and it will be led by Professor Olfa Hamzaoui. She's an intensivist from Université de Reims in Paris, in France, and one of the leaders on research on area and a close friend. We've been working together for more for many years. So thank you, Olfa, for being here. So the idea is to have we'll have your lecture, and then we have some a nice time to discuss, and we will close with some key messages on regarding the research network and some updates we've already done on future projects. Perfect.
Thank you. Thank you so much, Eduardo. Thank you, Glenn. Thank you for to you all of you guys for the nice invitation because I'm really very glad, very honored to be here. And yeah, as you said, we are friends for years, and the Andromeda experience, I think, made us closer and closer in these few years. And yeah, I'm very happy also to share this presentation with all the colleagues, Oliver, and all the Chilean, South American, and all the friends who are interested in hemodynamics. I was asked to try to give you an idea about how to assess vascular tone at the bedside. And first of all, I need to disclose my conflicts of interest, and here are them. Um, so how can we assess and what are the parameters that we have to assess vascular tone? Actually, of course, we have the systemic vascular resistance. I just put for you the formula of the systemic vascular resistance that is calculated, and sometimes it is, of course, displayed by some devices. So as you see, the first probably and the major, I would say also disadvantage, inconvenience of this systemic vascular resistance as the formula needs to have cardiac output. So the measurement of cardiac output is mandatory. And of course, so if you have, you would say, if I have a device with a cardiac output measurement, we may have the calculation of the SVR, but this is not a very simple and bedside, of course, way to measure. And the second, I would say, also problem of these systemic vascular resistance that are calculated in some devices, that they assume that the CVP, the right atrial pressure, represents the downstream pressure of the systemic circulation. However, because we have this what we call the vascular waterfall phenomenon in some circulations, regional circulation, the effective downstream pressure is often determined by the critical closing pressure rather than CVP. The critical closing pressure, I'm talking about the critical closing pressure in the venous system that is surrounding the vessels. Uh, and so, for example, I give you this study published a few years ago by Mathieu Sosviak, Denis Chemla, Jean-Louis Teboul, and Xavier Monet, and who are evaluating the effective of arterial elastance after fluid administration. And they also gave and they displayed the systemic vascular resistance, which was calculated by a device in some patients. And as you see, after giving administration of fluid, we have changes in systemic vascular, in the calculated systemic vascular resistance. However, this may be due not because of that the systemic vascular resistance changed. It may be, of course, but it may be also due to an increase in CVP above some of the organ closing pressures. So there is no change in vascular tone, and we have a change in SVR. We may have also a decrease in blood viscosity, and so we have a decrease resistance, which is not related to a vascular tone, but a decrease in this blood viscosity. We may have also a decrease, of course, in vascular tone because we have some flow-dependent vasodilation due to the arterial NO secretion due to fluids. This is one of the hypotheses, but not the only one. And and so you may imagine that this is difficult to know from the systemic vascular resistance, calculated systemic vascular resistance changes. And so SVR is far to be a perfect marker of vascular tone. And I would finish here my part talking about SVR, and I will move to something which is probably simpler and I would say more reliable at the bedside. And I will be talking about the diastolic arterial pressure. Why the diastolic arterial pressure is reliable? Because a low diastolic arterial pressure is mainly due to a depressed arterial tone. And this will, of course, make us think that probably at a glance, when we see these parameters in a patient arriving in the ICU or in the emergency department, that the predominant mechanism of shock is probably the vasoplegic mechanism. And of course, it will help to classify, and we will see also it will help as for other um, procedures. And I'm really, and I appreciate this elegant study that has been performed in 2007 by the team of Denis Chemla, Jean-Louis Touboulin, and Xavier Monet, who in 67 ICU patients tried to see the correlation between the different parameters of blood pressure and the systemic vascular resistance that was actually more accurately estimated by tonometry. And what they found is that the peripheral resistance is more related to the peripheral diastolic arterial pressure, but not really related to the systolic arterial pressure or to pulse pressure. That means that there is a significant correlation between these two parameters. So if you have these two information, that means that the diastolic arterial pressure may be used as a trigger when managing septic shock. And so it is interesting to introduce norepinephrine at that time if you have a low diastolic arterial pressure. And I want also to probably give you an example of how diastolic arterial pressure will probably motivate the physician to give norepinephrine, which is completely different from making all your rational and therapeutic rational around mean arterial pressure. And this is an example of a patient arriving to your ICU or to the emergency department, 70 years old, tachycardic, septic shock. And if you take two situations with the same patient, this situation A with a blood pressure of 92/55, situation B, a blood pressure of 111 and 45 millimeters of mercury. If you just focus your management on mean arterial pressure, the mean arterial pressure is actually the same. So you won't be able to have two different way to manage this patient. But if you take a look to the diastolic arterial pressure of situation A, for example, you see that the diastolic arterial pressure is not very low. So that means that the patient probably doesn't have a vasoplegic mechanism for the moment anyway, and the norepinephrine is probably not a logical treatment. And in the situation B, as you see, the diastolic arterial pressure is a bit low, and it is low for 70 years old, I would say. And so norepinephrine is probably the logical treatment. So this is how the DAP and the opposite way of MAP will be a trigger to start norepinephrine. And so the other question is, what is the cutoff of this diastolic arterial pressure? And we used to say that probably 50 millimeters of mercury from some old studies that we had around cardiac arrest. It is probably around these values. When we look at this observational study that has been published by Ashish Khanna a few years ago, with more than 77,000 patients in the ICU with sepsis or septic shock. And when you look at the group of patients with septic shock, we found that the 44 millimeters of mercury for diastolic arterial pressure was a breaking point in the mortality curve. So probably, I would say under 45 or sometimes probably even 50 to be more comfortable about the perfusion, and especially, and we'll see this, the coronary perfusion of the patient, we admit that the patient has a low diastolic arterial pressure. And when you look at the guidelines, and this is the surviving sepsis guideline, but not, of course, this year, it is a 2012. It was the guidelines about the really first hours of resuscitation of septic shock. It has been mentioned that you need probably to introduce vasopressors in a situation that is probably with a life-threatening hypotension, even if hypovolemia has not been resolved. And this life-threatening hypotension was defined in the rationale as a diastolic blood pressure was too low. Unfortunately, this has disappeared from all the surviving sepsis campaign guidelines. I'm showing the surviving of 2026, but even if you look at from 2012 until now, we are not talking about diastolic arterial pressure no more. And I think this is probably a mistake to when managing this type of patients, septic shock patients. But with some colleagues, and Glenn was also among the authors, we wrote, it was not after the 2026 guidelines, but it was after the 2021 guidelines, an editorial in order to give our vision to initiate vasopressor therapy, and together we emphasized about the individualization of this initiation, especially when you are focusing on the diastolic arterial pressure that will give you the best timing of introduction of norepinephrine. And another probably important thing to say about this low diastolic arterial pressure, in addition to it is a trigger to manage and to introduce norepinephrine. It is, of course, a parameter that will give you the predominant vasoplegic mechanism. It is also important because it is associated, a low diastolic arterial pressure is associated to a low left ventricular coronary perfusion pressure. And this is also physiology, because we know that the left ventricular coronary are perfused during diastole, and not as the right ventricular, the right coronary vessels that are perfused during diastole and during systole. So letting a patient also with a low diastolic arterial pressure will induce a low perfusion pressure of the left ventricle. And of course, this is a study that I cannot, a trial that I cannot miss, and I can probably even does not need any introduction here in the Andromeda network, as it is the Andromeda 2 trial. And if you remember um, the interventional group of the Andromeda 2 trial, comparing the capillary fill time uh, strategy versus the standard therapy in the interventional um, uh, arm, where there was a real phenotyping of the hemodynamic profile of the patients, the diastolic blood pressure lower than 50 millimeters of mercury was a trigger to adjust the norepinephrine dose. And one among other parameters, but this probably also explain the positive results of the Andromeda 2 trial. And interestingly, also, this is a very nice study published in Critical Care in 2026 that showed that actually, when in a population of patients with a low diastolic blood pressure, less than 50 millimeters of mercury, if you introduce norepinephrine very, very early, in within 25 minutes, you improve the mortality of these patients, with a significant difference between patients who for whom we administered vasopressors in within 25 minutes, compared to patients who received norepinephrine later than 25 minutes. However, in the patients where there was no low diastolic blood pressure, more than 50 millimeters of mercury, it is not, and this is logical, there was no difference in mortality between these two patients if you introduce in the early phase or not the norepinephrine. So early norepinephrine improved the outcome when DAP was lower than 50 millimeters of mercury, but not when DAP more than 50 millimeters of mercury. So this is, I think, the best trigger, and not a matter only of hours for the timing of introduction of diastolic artery of norepinephrine. Of course, diastolic arterial pressure may be affected by arterial stiffness, and this is also physiology. We know that the arteries are elastic structures that will amortize the discontinuous cardiac ejection, and this by storing a part of the stroke volume during the systole and by restituting it during diastole. And so what this is elastic arteries in young patients without any hypertension. But in older patients with probably some comorbidities, and especially with hypertensions, they have stiff arteries. So these patients with stiff arteries, as you see, the diastolic part of the aortic pressure is reduced, and so the diastolic arterial pressure will be low. However, I think it is important to say that diastolic arterial pressure may not be as low as when it is induced by vasoplegia. And this is a registry for more than 489,000 patients. Actually, it's not the patients with septic shock, but it is just to demonstrate that this phenomenon may reduce the level of diastolic arterial pressure, but not in a way like sepsis. So this is why we can use the diastolic arterial pressure when it is low, very low, as just a reflection of low vasomotor tone. And here in this study, when you look at the older patients with chronic vascular and non-chronic vascular disease, there is an increase, of course, with age of the systolic arterial pressure, and there is a decrease of the diastolic blood pressure. But as you see, the decrease with aging cannot be responsible of very low DAP values like the 40 that we see, for example, or less than 50 in patients. As you see here, there is a value of even more than 75 of diastolic arterial pressure. A second probably important point when looking at diastolic arterial pressure is that diastolic arterial pressure adjusted to the heart rate in order to reflect more the vasomotor tone. Because as you see here uh, in the figure that I'm presenting in blue, a heart rate which is not accelerated, and the red one when you have an acceleration of the heart rate. As you see, there is a shorter time of the diastole, and so there is less decline of the blood pressure in the during diastole, and so the level of diastolic arterial pressure will be higher than when you have a normal heart rate, which doesn't mean that the patient is not vasoplegic. This is why you need to take into account the heart rate when you are uh, uh, trying to interpret the diastolic arterial pressure as uh, a parameter to evaluate the vascular tone. As you see here, and I give you probably more an example of a situation one with a patient with a 51 of diastolic blood pressure, 100 of heart rate, the situation two with the same diastolic arterial pressure, but with 140 of heart rate. And the situation two, the patient is more vasoplegic because it is elevated because of this less, I would say, shorter diastole and a lower decrease of the blood pressure. And this phenomenon, which is of course a physiological phenomenon, has been taken into account and proposed by the team of Gustavo Spinatascon, Glenn Hernandez, Eduardo Catan, all the colleagues in South America, and proposed to adjust this heart rate, diastolic arterial pressure to heart rate, and propose what we call a diastolic shock index, which is defined as a heart rate divided by diastolic arterial pressure. And I think it is very important when you have a patient and if you have a doubt about the vasomotor tone of the patient, to calculate this diastolic shock index in order to see if there is a real vasoplegia or there is no vasoplegia. And what they reported uh, in this
Sì, todo, gracias.
retrospective study, there was two cohorts, a
Gracias.
preliminary cohort from Colombia and the second cohort, which is the Andromeda cohort. And the authors found that a value higher than 2.25 and 2 I would say 2.3 in the two cohorts, the Andromeda shock cohort and the preliminary cohort, will probably motivate clinicians to uh, introduce vasopressors, and of course, as a first line vasopressor, norepinephrine. So if you have a doubt, if you have a diastolic arterial pressure which is not less than 50, but the patient is tachycardic, calculate your diastolic shock index and decide after to introduce or not norepinephrine. And now we will go to another part when the patient is already under norepinephrine and you are, of course, just thinking about if the patient is not doing well, the evolution is not that good, and you are not sure if the patient has also some vascular dysfunction, some vasomotor tone alteration under norepinephrine, and so probably a hyporesponsiveness to norepinephrine. This is what we proposed with Antoine Goury, one of my team, and Jean-Louis Teboul, last year published in 2025. And of course, with the Andromeda team trial, because we retrospectively studied the Andromeda 1 trial and checked the validity of this ratio in this cohort. So this is why, of course, with Glenn Hernandez, Eduardo Catan, and Jan Becker are also among the authors. And what we proposed is that to adjust the diastolic arterial pressure not only by heart rate, but also by norepinephrine dose in order to define what we call a vascular responsiveness to norepinephrine. And this is what we reported is that when we studied this ratio in the cohort of Andromeda, we found that the VNRI was really the most significant parameter associated to mortality, even higher than, as you see, the PC2 cap, Apache-2, SOFA, and all the severity scores. And interestingly, we found this curve an inverted J curve with mortality, and we found and determined a breaking point which is around 2.6. So this is why we concluded that a low ratio, a low VNRI less than 2.6 is probably indicating a hyporesponsiveness to norepinephrine, and probably, and this is we will try also to work on it on another cohort, but probably will be a parameter that you may use to optimize your vasopressor therapy and probably to add a second line vasopressor. And if I want probably to more detail and illustrate this situation is I give you three situations with the same diastolic arterial pressure. The first situation, you have a patient under 1 microgram per kilogram per minute of norepinephrine with 51 of diastolic arterial pressure and 115 of heart rate. The situation two, you have the same heart rate, the same diastolic arterial pressure, but not the same norepinephrine dose, which is lower. So, of course, the patient with a higher level of norepinephrine and the same level of diastolic arterial pressure has probably a lower responsiveness to norepinephrine to compare to situation two. And if you take from situation two to situation three with the same diastolic arterial pressure, the same dose of norepinephrine, but a higher heart rate, this patient probably also has lower vascular responsiveness to norepinephrine because actually the diastolic arterial pressure is probably also lower. The vasomotor tone is lower than what is reflected by 51, and this is why this ratio may be helpful at the bedside. And this is how can we use it at the bedside? Here in a patient with pneumonia and a norepinephrine 0.6 microgram per kilogram per minute of norepinephrine. He already received crystalloids and he had always blood lactate. Echocardiography do not show any cardiac dysfunction. And you are asking yourself, do you need to give more fluids to increase norepinephrine? Or probably it is the time to give vasopressin. But if you look at only the recommendations. For example, the Surviving Sepsis campaign, I'm showing the 2021, but the 2026 are the same. What the recommendation tell us? It suggests that we need to add vasopressin instead of escalating the dose of norepinephrine. And in the remark part, they suggest that this needs to be between 0.25 and zero point 0.5. Yeah, this is base norepinephrine. What I'm showing, it was a tartrate. So we need to multiply by 2. I had zero point 0.6 micrograms. So it is more than the interval. We're just at the limit of the interval of introduction of norepinephrine, of vasopressin. So what will I do? Should I introduce now or wait a little bit? Because between 0.25 to zero point 0.5, or if we convert it into tartrate from 0.5 to 1, it is from a simple dose to a double dose. So we have a big range of values. It's not that precise. So what should I do? I wait, I introduce now, or I wait and see. So if you look at the recommendation, this cannot help you. But if you calculate your vascular responsiveness, you will see that the patient have a ratio of zero point 0.8, which is very low. So that means that the patient is probably have a hyperresponsiveness to norepinephrine. And this is why you need probably not to wait and to introduce vasopressin. So if I summarize all these concepts, how to assess vascular tone at the bedside. We have the systemic vascular resistance, yes, but it is far to be a perfect marker of vascular tone. Of course, you need to have a cardiac output in order to calculate it. But I think simpler is the diastolic arterial pressure, which is at the bedside. You have a low DAP, which is mainly due to a depressed vasomotor tone. So it is reliable and you can use it to trigger the introduction of norepinephrine to give you the mechanism of shock. You maybe use it, of course, as a trigger. And if you have the patient with tachycardia, DAP needs to be adjusted to heart rate. So you may use the diastolic shock index in order to introduce in such patients the norepinephrine and to be sure that the patient has a low vasomotor tone. And of course, if you are doubting about the vascular responsiveness, you may even calculate the VNRI and see if the patient will need to have a second vasopressor. And with all these concepts, I would finish my presentation. I will say muchas gracias. Thank you so much. Merci.
Thank you, dear Alpha. It was wonderful. Super nice presentation. Very refreshing and very integrative and very, I loved it. Thank you very
Thank
much.
you so much. Thank you. Thank
It
you
was
so
great.
much. But anyway, they are the concepts that we are working on them together. So this is not very, I would say, very exotic for you. It's something that we discuss a lot together.
Yeah. But seeing it like in this framework and going from SVR to vascular responsiveness, I loved it. It was super. It made all the pieces come together in my mind at least. So I really appreciate your presentation and this how you took a very complex topic into very simple, let's say, wording. And I loved it. Thank you very
Thank
much.
you so much, Eduardo. And you know, of course, because of also the help of all of you, team, we try to check all this and to validate all these concepts and try to move on to in the physiological uh, rationalizing
Mm.
the management of the patient at the bedside based on physiological concepts. And this is, of course, your team, but also my team, and this is how I think we will move on in these concepts.
Yeah. Eduardo, can
Glenn?
I?
Yeah, please.
Yep.
Please go ahead.
So congratulations. I mean, it's fascinating topic, and you're a fascinating.
Thank you.
You gave a fascinating lecture, a speech. It was fantastic. I
Thank
really
you.
appreciate it.
Thank you,
And
Glenn.
we are a growing up network. We have the strength of our network is in the studies that we have already performed, and we have many plans for the future.
Yeah,
So these monthly colloquium are a way to maintain us connected, alive, and to incorporate young people, especially to attend and to hear about these new ideas and professors and get stimulated to participate in the future research. This is the aim of this meeting, and I appreciate it very much. From a personal point of view, I remember that more than 10 years ago, 12, 13 years ago, I spent a mini sabbatical with Jean-Louis in Bicetre the first time, and then I kept going twice a year for 1 month for some years. And I remember the small talks, in the office, Jean-Louis and Denis Chemla came, and
yeah,
then you were around always. And then the first time I remember he said, okay, the diastolic blood pressure has been neglected because it's for me, he said, it is high Maldi's it is the most accurate clinical from a clinical point of view a way to monitor somehow the vascular tone. I remember, and then I remember we were talking about that, and he said we have to adapt for heart rate at that time. I mean, more than 10 years
yeah.
ago. And then in further, this is the relevance of these small talks between friends that love physiology, And then with Gustavo Spina, he said, why don't we just, and then we did the diastolic shock index.
Stock index.
Yeah, and
Yeah.
this is a progression of the idea. And then you came up all fine raves and all the study with this, the responsiveness index. I love the concept. I love the data. My only problem is with the name. It's a little bit complicated to
Yeah.
spell.
We
I
didn't
told
find any other name,
no,
We
yeah,
did.
Jean-Louis and you told me, Glenn, give us a more
Yeah,
poetic name for this
a
index, but
poetic name.
I
Yeah.
couldn't come up with any more thing. And also, it's very interesting that in a couple of recent studies, one of them is the paper that you cited from Dr. Ko, Ruyen Ko from
Yeah.
South Korea in Seoul. By the way, she's also part of this network. She participated in Andromeda Pegasus, and we are very fond that he is also a member. He published this very nice paper about the relationship between, the
It's
diastolic blood pressure,
diastolic.
early norepinephrine versus.
Yeah. Yeah.
And in concerning the Andromeda 2 study, um, when you look at the data, what we obtained with the intervention algorithm, some people told me I'm a little bit disappointed because in the patient that went to the diastolic arm, let's say diastolic augmentation, when you see the crude numbers, let's say, or percentage of success, it was only 27% patients that went to this part and were intervened, rising diastolic blood pressure by a short increase in norepinephrine dose. But 1 in 4 patients, if you look at the other way around, one in
Yeah.
four patients that otherwise would have received more fluids and more fluids normalized CRT just by increasing diastolic blood pressure to 50. Remember, but if you look at the more in a broader view of these results, we were very strict in Andromeda 2. We aimed at normalizing CRT, meaning CRT less than 3. But if you look more globally at improvement in CRT, for example, a CRT from 6 decreased to 4, not normalized, but had a trend, then the success of this intervention was more than 50% of the cases. So it's
70%, I think.
yeah, something like that. So it's worth, in my opinion, and we will do, of course, in further studies to look more closely at this because I think it makes physiological sense. No, I think it's
Maybe what would you think, Olfa? Because we only saw the DAP, maybe if we check if the patients on the vascular responsiveness, maybe we could find a signal for a post hoc in this subgroup
A
of
post hoc,
patients.
Yeah.
yeah.
Yeah, I think it's probably of course, you know, the patient with hypoperfusion, I would say there is a lot of mechanism that may induce this hypoperfusion. One of the mechanism is vascular dysfunction, and vascular dysfunction is either because the patient has a vascular dysfunction. Um, it may be reflected by just a low diastolic arterial pressure, but it may be reflected also the patients who are under vasopressors, because we may probably not detect and identify as the diastolic arterial pressure is 50 or more. Patients who have higher values of norepinephrine and higher heart rate, because we just concentrated on the diastolic blood pressure. And of course, these patients who are, as I showed in the slide, if you have 55, for example, but uh, you are not eligible to have the increase of norepinephrine because you reached the more than 50. But if you have 55 and you are under 1 microgram of kilogram per minute of norepinephrine, and you still have a low CRT, that means that you have something which is wrong, and probably a real profound vascular dysfunction. So this is why I think, yeah, the identification of the patients is probably, there are some patients who are uh, not very well classified because of this, because they are under vasopressors, and of course, because of the heart rate also sometimes.
Yes,
So I
I
think
think it's
it's a way
an
to do.
interesting avenue.
Very
Yeah.
interesting. Oliver?
Oliver?
Yes, so thank you all for this great and very didactic structured talk. Brilliant. I will present
you.
that to my junior doctors, and I'm sure they will love it.
Thank you so much.
One thing we usually think about, if we increase the diastolic pressure to 45 or 50, then we usually look at the mean arterial pressure that results from these vasopressor increments. Do you think that might be an interesting approach for the future to find the optimal mean arterial pressure in these patients? Because my impression from Andromeda
Yeah.
2 was if we calibrated the diastolic pressure then to 50 by increasing norepinephrine, we often ended with a much higher mean arterial pressure than 65 in some patients. We had 70, 75, sometimes 80. And if the patients then benefited by decreasing CRT, as Glenn mentioned, this was a high number of patients, then we kept that diastolic pressure, and of course we kept that higher mean arterial pressure. Is this something to recalibrate the cardiovascular system with the lowest pressure, which is the diastolic pressure, and then we have a look at the mean arterial pressure as in this situation maybe the optimum? Is this something
Thank you,
that's
Oliver. Thank you, Oliver, for this excellent point. Actually, you know, mean arterial pressure and diastolic arterial pressure are closely correlated. And you know, there is what we call a thumb equation that is correlating the mean arterial pressure by calculating it by 2 times diastolic arterial pressure with plus you add the systolic arterial pressure and you divide all by 3, which is a formula that had been validated. So actually, both of them, they are correlated. So if you have, for example, very low values of diastolic arterial pressure, you should have also very low diastolic mean arterial pressure. They are really very close. It is exceptional that you maintain a mean arterial pressure with a very low diastolic arterial pressure. And sometimes exceptional, why I'm saying is exceptional, if you have patients who have an aortic regurgitation, a very important aortic regurgitation, where you have high systolic arterial pressure and low diastolic arterial pressure. And with this, you may maintain a mean arterial pressure, which is in the ranges. But I think if you have, of course, a diastolic arterial pressure which is low, even though the mean arterial pressure is 65, which is normally not the case. But if it is the case, you should focus on this diastolic arterial pressure also, because it is something that you need to correct, not as a goal, but as a trigger, as I said. But probably you may, yes, but this is one of the parameters that you need to personalize blood pressure for the patient. Yeah, you're absolutely right. If you need more for the diastolic arterial pressure, so probably you need more to increase more main arterial pressure. So this is the way we need to do. And this is, I think, Andromeda 2, what also showed us is that an interventional arm built on the real individualization of all the hemodynamic phenotypes that are based on simple parameters of blood pressure, pulse pressure. When it is low, that means that there is a low stroke volume. So you need to see if patient is preload or responsive or not. Diastolic arterial pressure, mean arterial pressure as a target, and probably a map test if the patient is still hypoperfused. So I think this is the way we should do. All the parameters need to be integrated, not only one, and not not only one parameter, but all the parameters of the blood pressure.
It's very, can I, it's
Yeah.
very, very, this is very interesting. I remember when we, from a theoretical point of view, after many, many versions, we came up with the final algorithm for Andromeda 2. The first algorithm was you had to go to the university to understand it. It was too complicated. It was terrible. Then we tried to make it simple, 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 simple. And then we came up with the final version. But I remember with Eduardo, we were at the bedside in the ICU in this preliminary phase, practicing, with some patients, I remember the first case, a successful case, was an old woman with the peritonitis. She just came from the OR, and she had a CRT of 7, and then she had a MAP of 65 with norepinephrine of 0.08 low dose, but a diastolic blood pressure of 43. So we said, okay, let's go for it. Now we increased the norepinephrine like we were like childs, playing with a new toy. We increased the norepinephrine a little bit to 0.12, just. The MAP increased to 70, from 65 to 70, and the DAP from 43 to 51. And with this stable situation, we waited for 30 minutes, 40 minutes, and CRT decreased from 6 seconds to 2.9 or something. It normalized. But of course, we don't know what's maybe this little increase in how this, when you increase a little bit norepinephrine, you modify, of course, MAP, sometimes DAP. But what happens with the critical closing pressure? We don't know. We cannot measure. But it worked. It worked, and we were very happy. And this reinforced the idea to put this in the algorithm. And my friends always tell me that I am a spoiler. I spoil things. But we are working with the genius mathematician. We are trying based on data of Pierre Grégoire Guinot. Guinot.
Yeah.
He published in post-operative patient after cardiovascular surgery. He calculated the PCC, the waterfall, blah, blah, blah. And we had access to his database. And with the genius, statistician, mathematician, we are trying to develop an equation to calculate this without, based on this data. And what we can say until now is the only thing that can spoil is that the diastolic blood pressure is the variable that correlates with the PCC. It's the only one. I mean, it's close. I mean, so what I'm trying to say is that diastolic blood pressure is fascinating, no? It's a fascinating variable
Yeah.
that has not been deeply explored in clinical trials, even in physiology, there are some doubts. So I think we can work this together. I think this is a good plan for the future, of course, for post hoc analysis of the data that we already have in the Andromedas,
Yeah.
etc.
Yeah. We have already a project to explore more the data of Andromeda 2 with the diastolic blood pressure, with all these parameters, the diastolic shock index, the VNRI, the diastolic in
All
itself.
this, yeah.
Yeah,
Great,
in
great.
order to see what is
Pablo,
in 1,500 patients, it is important to see to challenge these parameters and to see how they are reliable at the bedside in the real life.
perfect.
But I think actually you said that the first algorithm you need to go to university to
Yeah,
study. When I was as I was the PI of in France, so I was presenting the Andromeda 2 in the centers, all the centers. So I was with my presentation, and when I put on the screen the algorithm, and the people, they were just scared, terrified. But this is, but Olfa, this is complicated. This is very complicated. I
This
said,
is the first reaction. Yeah, yeah.
And this was the simple version. Imagine the
This
yeah,
was
other.
the simple version, number
this
65.
even in my unit. And I said, no, come on, guys, you cannot say this is it's not because there are some errors that it is difficult, but actually at the bedside, this is what we do. We look at the pulse pressure, we look at the diastolic blood pressure, and we look at the mean arterial pressure. We didn't put them in an algorithm with some errors, but this is how we manage at the bedside our patients. But of course, it depends of the centers, because yes, we are very, I would say, influenced by all this culture of simple hemodynamic parameters, and even more complicated. But there are some centers uh, who are not used to use these even in France, and I think all over the world. They don't use these simple parameters
Yeah.
in that way. But it was really a brilliant idea to put all these parameters in an interventional arm and to use it at the bedside.
Okay. So, Eduardo,
Yeah. So I think we're coming to the end of our colloquium. We're about to get on time. I want to personally thank Olfa for sharing with us the whole hour in the presentation and this discussion. Also to Oliver, Glenn, and everyone who has connected and made
Marlis.
this.
Hi, Marlis.
Marlis,
Marlis,
hi
yeah,
Marlis, how are
the great
you?
Marlis. It's a nice
How are
name.
you?
Well, Eduardo, can I make
Yeah,
a very
sure,
small,
sure.
short remark? Is that
Yes.
we will put this, we already started in May with the first colloquium, and then this is the second. We will put all these records in a YouTube channel, free access. And I'm sure that
That's great.
people, yeah, people, because people have just started to notice this. I mean, so the attendance will grow up, and then many people will access the YouTube channel, and then this is a way we will communicate with and
Yeah,
also provide their news about the ongoing research projects, future research projects, etc. So I'm sure that these people will look at
Yeah.
this
The
video, at this record
the
in the
first one.
future, and they will regret not being on direct. They will regret. I'm sure of
they
Glenn,
that.
will regret.
the first one has more than 500 views in YouTube. So it's
How
been
many? How
a
many?
huge, more than 500
Ah,
so
yeah.
500 views in YouTube. So it's a huge success, and I know that this will only grow up. And our next session will be the last Wednesday of every month. The next one is July 29th. So that's the upcoming date. We will send you soon the program to all of you. And you are deeply invited so
Yeah.
we can share, we can
Finir dans 2
discuss.
minutes.
It's a great opportunity to meet with friends and to keep this community alive.
Okay.
And a big thank you for all for being
Eduardo,
here.
give me news about the views of my video.
Yeah,
Okay,
yeah.
so to
of course.
see if there is
You have
any, I love competition.
okay. You have to beat Ricardo. You have to beat Ricardo. That was the first one.
I need to
I
be
know, and then,
the
and then,
record.
Yeah,
Yeah.
yeah,
and then there was,
yeah. You'll be in
this
the
has been
podium.
a,
Yeah.
Eduardo, this has been a fantastic week because a couple of days ago we had the meeting of the CD section of the
Yes.
ESICM with
Yeah.
Antonio, etc. And
Yeah.
he spoke about a collaboration, a free, independent, but a collaboration between Andromeda Network and the CD section in the future to work together in some project. So we are very happy. So I'm
Yeah.
glad
We are
to see
also very
you.
happy.
Yeah.
Yes.
Thank you so much for the
Thank
Thank
invitation.
you.
you.
Glenn, Eduardo,
Thank you.
nice to see you, Oliver, Malis.
Yeah.
And
Hope
see
to
you
see you
soon, I
Nice to
soon.
see
hope.
you too.
Yeah.
Bye.